Everybody, good afternoon. Well, shoot, I want to say good afternoon, but I guess it's still good morning. So, hi, everybody. This is Andy, Elsa, and the CCSP team. And Lori Workman is joining, Elsa Weltsing, Andy Dwyer, and it looks like we have several folks joining in. So, it looks like we're just over 20 people. So, we will go ahead and just wait for a few more people to enter. So thanks so much for joining in today for the CCSP program partner and community partner and clinic partner meeting. We are thrilled that we do have funding for this next additional year to conclude the 3-year part of our grant of 3-year cycle. So we're very excited about that. We'll share a few of the specifics around the grant and where we are to start. So it looks like several of you are just connecting now through audio and visual. Elsa, any notes to our friends at home from a tech support side before we get started?
Hi everyone, thank you all for joining. You all are muted upon coming in to the meeting. We'll have opportunities later on to come off of mute when we have some discussion at the end, and you can control your audio and video at the bottom toolbar. If your audio is joined by phone, later on, if you'd like to come off of mute, you'll press *6 to come off mute. If you all have a camera and you are able and willing to share, we'd love to see your faces. And as we're getting started, if you could all put your name and organization, where you're joining from, in the chat, we'd love to see who's on today. And thank you all very much.
Okay, great. Elsa, do you want to go ahead and we can bring up the slides for today and get started?
Yes, I will go ahead and share my screen.
Okay, very good. Okay, well, it looks like we're getting people putting their names and clinic systems, as well as which organization you're from. So a huge thank you and a shout out to all of our federally qualified health centers, critical access hospitals, and rural health centers for joining in, as well as our team members from countless groups of hospital systems and treatment centers, and our community-based program partners as well. So thank you. We wanted to start the year off. I guess we're about a month into this fiscal year, giving a bit of a state of the state of the CCSP program, talking about where we've met milestones, where we've seen some great work done over the past year. Hearing also from a couple of our partners who are great supports for us through the cancer prevention work, with Christy Cahill as the Executive Director of our Colorado Cancer Coalition. And then RJ Hours, I believe he's able to make it today to talk a little bit about some of the work that the Cancer Action Network and ACS partners are supporting in terms of overall colorectal cancer initiatives. So today is really providing education, background, and support. One of the things I just want to say is right now CCSP is not directly involved in any policy initiatives beyond providing education and support. But we are going to hear a little more of a rounded out perspective about what are some of the additional connections to overall increasing cancer screening and prevention, navigation, and supports within the state, with Christy and with RJ joining in today from the different perspectives. So we're really excited to have them with us. Just before that, we will talk about some of our specific plans for the future, and then hear from all of you about the discussion and where we're moving. So we're going to be pretty snappy today, but we also really are excited about having some external partners joining us in for the presentation. So looks like we have just over 30 people ready to go. So Elsa, I think we are set. Anything else to share before we get going?
I think we're good.
Okay, next slide. And I want to say a huge thank you to Lori Workman, who is a part of our CCSP team. For all of you who are direct partners, you know that Lori will be actually retiring in August. So a quick note, if you hadn't got that update and the like, we will be following up with specifics about direction for the reimbursement for the work, and connections with our program from the fiscal and administrative side. So Lori's helping cross-train, and we've got that covered. So don't panic, but I do want to just say that Lori has been an amazing part of our CCSP team, from the fiscal to accounting work. She's just been an amazing advocate for our clinic systems, for our program. She stuck with us, really with the contracting. It could be onerous sometimes, and there's a lot of different elements and complexities, and Lori has handled it beautifully. She's been a strong advocate of the medically underserved and the programming and the work that you're all doing. So I just want to say a huge thank you to Lori. She will be greatly missed, and she has been a longtime friend and colleague, and I will miss her extremely much, but we are very excited that she's on the call today, and that she will continue to help support us, even if it's peripherally. So Lori, I'd love if you could come off mute and say a few words for folks at home. And again, Lori, a million thanks for all of your great work. Lori?
Well, the first thing I could say is if you saw me right now, you'd say, who is that person? Because I look nothing like that right now after being home for 5 months. But anyway, yeah, it's been a great experience. I just finished my 12th year with the program and have been there through a lot of ups and downs. I still know some of you guys. You've been there since the beginning as well. I came into the program with no medical background whatsoever. It's all been public education, and I've learned so much. It's incredible. I doubt I would have stayed with the program this long if it hadn't been for Andy. She is my best friend. That's all I can say.
We are best friends forever. So yeah, you two can, if we work together, we will all become best friends. But I love you, Lori, and we do thank you for everything that you've done. And I was actually telling someone that I don't know if it's ever possible to actually see someone in accounting and contractual services that really totally gets the mission and vision of programs like this. But Lori, you really have embraced this, and it has been ups and downs, as you all know, with our funding and many of the different bureaucratic obstacles, but thank you a million. So we will continue to give everybody an update and getting you all connected and making sure Lori's put us in really good favor and on solid ground to move forward. So thank you guys so much for all of your work, and we'll, next slide, we'll go ahead and get started talking about really where we are. So just as a quick reminder, in the time that Lori was talking about, that 12 plus years ago, when we did start with the program from 2007 to 2013, all of you who knew the program at the time, we were really a robust and flush program with about $5 to $7 million per year. We were able to provide direct screening services and navigation. So at that time, we were providing support for colonoscopy, some FIT and FOBT testing, and even had purchased colonoscopes at the time to help with the capacity building. After the ACA expansion in 2014 to current, we did continue to really focus on that navigation aspect, and that's really what the grant focuses upon. And so what I want to say, though, is that one of the things that we learned is that navigation was much of a driver as any of the direct services. So I just want to say that it's unfortunate that in some circumstances, we have not been able to provide support for people for the direct medical components. But we have always been able to support people into those navigation, into colorectal screening, now growing to lung and to family history work as well. And those have been exceptionally effective. And those navigators have continued to advocate for services beyond, really looking at securing additional services for medical care and the like. So thank you again. We're still really thinking of having conversations, and we'll have some of our partners joining us telling a little bit about maybe how we can expand, especially in this difficult time for direct services, and how we can help supplement funding in the future. But just as a quick reminder, this is really what CCSP has been about: barrier reduction, access to care. And we are funded by the Cancer, Cardiovascular, and Pulmonary Disease Grants Program. We are one of the longest standing programs, and I have to say that we're really fortunate to be funded by them, and I think they're going to be looking at some new future directions, but we are going to continue to advocate for cancer screening. Even if the program doesn't look and feel like it always has in the future, we will look at other supports for moving this work ahead. So next slide. So overall, our goals have been to improve screening rates in Colorado overall, with colorectal cancer as being our main thrust for the medically underserved. We really have been in accordance and compliance with the American Cancer Society and USPSTF guidelines, but specifically with ACS National and our affiliation with the National Colorectal Roundtable. We have really been adherent and really thinking about that 80% in every community. We actually even know some of our populations in Colorado have hit an 80% screening rate. Some of those plans that are Medicare based particularly, but we also know that there's communities where screening rates are still in the teens or 20%. So we really need to think about health equity and access, and that's really what CCSP has been about. So how are we really working? It's through all of you. We have really facilitated this program through safety net programs, our clinic systems, the navigators, all of you working in the field, our Cancer Coalition, our American Cancer Society, our treatment and specialty clinics. And so since 2007, we have navigated over 30,000 people. But when we've counted our individual partners, it's up in excess of over 300 different clinic systems, community organizations, or hospitals. So this has truly been a statewide effort, and we thank all of you through all parts of the Colorado for being engaged with our work. Next slide. So we have, and the program continues to really look at incidence, mortality, screening rates, as well as the demographics of our state to really think about allocation and resources, and then also share with decision makers around what we should be considering in terms of access and care. Just as a reminder, and I think there's been an updated map since then, but just as a quick reminder, our state health department and several of our partners, including our state cancer plan, do a beautiful job of actually sharing information about screening and early detection, as well as cancer treatment and survivorship. But this is actually a really great resource coming out of out of CDPHE that shares, and you'll notice the darker regions of Colorado are those areas where we see higher stages of late stage diagnosis. And the smaller the dot and the darker the dot, the lower the screening rate. So what I want to say is I think all of us can really look at the regions of where we live, where we work, where we play, where we're from, and really think a little bit about the impact of colorectal cancer within Colorado. Also, as I've mentioned, we have grown to lung cancer screening, piloting work, and also thinking about hereditary syndromes and hereditary cancers. We need to be thinking ultimately, what are the rates and access for screening, early detection? What do we know about rates in our region? How do we proactively really address the issues? But one of the things I want to also say is, where do we celebrate success? So in the more lighter regions with bigger dots, those are regions that we see decreased mortality or late stage disease and increased screening rates. So these maps are great, they're helping guide us, but I think we also want to keep really strong tabs on where we're winning and losing in Colorado, and how do we really think about a statewide approach to really increase screening and reduce cancer incidence and mortality. So again, I hope you found yourself on that map. I hope you really looked at that. I think of maybe how you have conversations in your community about what this means, but data really does drive our program. And we also thank all of our program partners who provide this sort of detail for us in our community. Next slide. So what I want to focus on, and Elsa Weltzine is going to give a great overview of our statistics over the last year or two to give an idea of really what we've accomplished in this grant cycle. But as Lori mentioned, some of us have been with the program in excess of a decade. And ultimately, when we look at this sort of impact, we have screened over 30,000 people. In terms of the case for navigation, we still have a less than 10% no-show rate. Our adequate and bowel prep exam and our complete exam are well over 90%. For those of you back in the day who remember when we started this program, many of our partners were actually reporting no-show rates as far as 75% of the time people were not showing up. And we know that that no-show rate now is well below 10%. So we know about 90% of the time people are showing. We also know people weren't adequately bowel prepped, hadn't necessarily been educated about sedation and the like. But now you look at that, over 90% are coming in who are really prepped and ready to go. That's huge. We know that we have actually detected over 230 cancers that, if found later, would have actually gone to late stage disease, and many folks would have died. And based on our estimates of the types of polyps that have been removed through our program, we actually think that we have prevented over 500 cancers. And if you look at what the cost would have been to have those folks treated, even after the minus of the cost for the program and navigation, we're still showing probably conservatively at least a $15 million savings to the system overall. That's even after the investment of this type of screening program. So the proof is in the pudding. This is what we're dealing with. This is why we're really making this case. And we're going to talk about sustainability and how we keep this moving. But again, these are the great results of all of the great work with all of those partners. So huge thank you to all of you. Next slide. So really, again, the CRC screening and the navigation, all clinics are implementing that. That's been the foundation of the work. In terms of the implementation of our family history and screening, we started with the pilot of this work with Marillac Health Systems. This is actually now grown to Uncompahgre Medical Center as well as Denver Health. The lung cancer screening pilot work started in concert with the National Jewish Health, who's still a partner in this grant. We're implementing with Brunner Caritas and currently also with Summit Health Systems up in the mountains. And then we're really looking at the examination of how do we sustain this work moving ahead. So grant funds don't live forever. These are the types of things that we need to consider with our CDPHE Workforce Initiative, our statewide alliance, and others. And we've been really concentrating on this last year. And I think the other thing that we really have done is also really working with our breast and cervical program and all of our partners to really think about preventive cancer screening at large. And again, I think this slide really reiterates that need for whole person care in cancer prevention and control, and not just by body parts. So we really have been considering how do we grow the cancer prevention work. And I want to say, and I think all of you have known and seen this, and we've stressed this, this is no more important than now, given the COVID-19, the backlog of patients to be screened, as well as the projections of what we know about possible mortality rates. So we do have a huge opportunity when we think about prevention and wellness now that the elective procedure ban has lifted, and thinking about how we do this work together to increase screening by all modalities for all body types is going to be critical. Next slide. So looking to the future, our funding is set to end about a year from now to conclude this entire grant cycle. There's a possibility of an extension year. We're not sure that that will happen. Our health department is going into some very strong and detailed conversations about what their projections might be for opportunities. If there was another state of fiscal emergency on the table, and if that would pass, these grant funds would be in jeopardy. We did escape that narrowly from our last legislative cycle. There would have to be 2/3 majority through the legislature to have something like that pass. It did not pass, so these funds were actually not in peril because of that, but the reality lives that it could happen again this year. Although slight, we are just watching and monitoring just to make sure that we can continue to support the program. And then ultimately, in terms of looking at strong sustainability of our program, Elsa's going to talk about that in more depth, but our strengths are really that we have champions and engaged staff and leadership. But the gaps are that ultimately funding, and especially for our medically underserved and undocumented patients and how to navigate those who don't have payer sources, still remain difficult in terms of also securing FTE support for navigators for the long term. But again, we're going to continue to advocate and show the impact of this grant to talk a little bit further about developing the workforce. And again, that effects of COVID-19, something we have to take definitely into account. So we'll be having more dedicated conversations. We'll be working with more of our partners around these efforts. And again, a huge thank you for all of the great work. Next slide. So I think, Elsa, I will turn it over for you to share the data from our grant cycle thus far.
Thanks, Andy. So I had shared some of our preliminary data for those who were able to be on our July call last month, but we now have our final data for the previous fiscal year, FY20, that ended on June 30th. So I'm delighted to share our final totals. Even with COVID-19 really reducing and almost completely stopping all screenings between March into early June, the program was still able to screen over 2,700 total patients, including those that met the eligibility criteria for the program. And we know that those clinic systems are also navigating several others that may not meet the program requirements. But there were 2,020 CCSP eligible patients that were successfully navigated all the way through into their colonoscopy. And of those patients, there were only 5% no-shows. So that's far below our no-show rate of the program overall of 10%. And we're now collecting data on cancellations and seeing that at about 15%. And it'll be interesting to see how that changes into the next year of the program and if we can maintain those low rates. Come on, slide. There we go. So looking at some of the outcomes and demographics of those screened on behalf of the program, in alignment with our overall program rates for prep quality and CCUM reached, we were seeing about 92% adequate prep, 95% of complete exams, meaning that if the exam was incomplete, some of those patients would have to reschedule and come back another time. So that really helps save resources. And we're now tracking screening outcomes in some deeper categorizations to really look at those advanced polyps as well as the other types of precancerous polyps that are being removed during the colonoscopy. So we're seeing about 6% of patients have an advanced or high risk polyp that is most likely to develop into cancer, and there was a 0.8 cancer detection rate. Very consistent with previous years. The program is screening more patients that are under age 50 than previous years, seeing about 14% under the age of 50 due to family history or ACA guidelines. And we're continuing to try to reach and successfully navigate those that are medically underserved and reducing those health disparities, including 42% of the patients screened were Hispanic origin and 44% had Medicaid and another 14% uninsured. So our uninsured patients, we've been screening more of those ever since we were able to get an exemption from the lawful presence requirement in Colorado. So more access has been reached for those who are undocumented, but we still have a great number of strides to go. And then if we compare this grant cycle as a whole, so the last 2 years to the previous grant cycles, in previous years, all the way up until 2018, we were screening more females than males, really concentrating our efforts on those ages 50 to 64, screening about over 50% non-Hispanic white patients and 40% of other races and ethnicities, and really focusing our efforts on screening colonoscopies, so true screening for patients at average risk, or getting a screening colonoscopy at an earlier age due to family history, with some efforts focused on diagnostic follow-up stool test colonoscopies and surveillance colonoscopies, but still maintaining those adequate prep rates at about 91% overall, 95% CCUM reached. And those, as Andy mentioned, when the program first started, we'd really had much lower rates of adequate prep, complete exams, higher no-show rates. But by 2018, those numbers were improving every year, giving us that average rate. So if we look at the current grant cycle in comparison, we are now reaching about equal percentages of males and females, which is excellent because colorectal cancer, as we know, really impacts both genders equally. We're continuing to reach people in the screening age of 50 to 75, but also increasing those less than 50. And overall, the last 2 years of the grant cycle, over 50% of patients were a race or ethnicity other than non-Hispanic white. And we are increasing the number of patients that are getting a colonoscopy either for surveillance from a previous abnormal result or because they need a diagnostic colonoscopy, including many of our clinic systems are implementing stool-based testing as that first line of screening, and those who have a positive result then go on to get that colonoscopy in order to get more patients screened. And our prep quality rates have really overall been higher than the previous years of the program, and still about 96% complete exams. And having a lower no-show rate, we've gone from about 10% to 6%, so continuing to see strides in that area. And so we've been sending each clinic system their individual program data as well to really look on the year-by-year comparisons of 2018 through 2020. And so we've gotten those out to many clinic systems. If your clinic system hasn't yet received it, you will be getting that information soon as we check in with you at the beginning of the new fiscal year. So just wanted to give a huge thank you to everyone, all of our navigators, and the whole clinic team that really work day in, day out to connect with your patients, educate them about the importance of screening, the preparation process, and getting them through to a complete exam. So all of this work and these outcomes would not be possible without all of your support. So if we take all of this data and we look at our current capacity for sustainability, we're really looking at where clinic systems are at right now to sustain the role of navigator for preventative cancer screening right now, and as CCSP funding gets ready to sunset. And so as Andy mentioned, our clinic systems have really expressed by coming together from many different perspectives and roles as a small group in each clinic system, talking about their strengths and some areas for improvement. Almost every clinic system that we've gone through this process with, and that's about 15 clinic systems, almost all identified that they have strong champions for the work, engaged staff and leadership at all levels. Staff really understands the importance of navigation for cancer screening, and they're dedicated to continuing to offer these services. And also through the navigators really engaging with their community and their patients. And they overall feel like they have the resources to continue this work in some capacity. However, there are some areas where they see some opportunities for improvement. And so in this current grant cycle, each clinic system, many have gone through this process already. And there's just a couple of you all. So if you haven't yet gone through this process, start thinking about maybe some of these domains, which are based on the structure from Washington University in St. Louis, really looking at this framework, thinking about what domains you might address if you have not yet started this process. But of the clinic systems that have gone through this already, the majority are focusing on strengthening their workflows to make sure the role of navigator is really integrated. Everyone understands their roles and responsibilities, and if there's been organizational changes, to making sure their workflows are updated to reflect the current guidelines and changes in their organization. Some clinic systems are really thinking about their communication plans internally, making sure a sustainability plan is built into their strategic planning, or looking at how they could build a business case to support funding through their internal infrastructure, and bringing that business case using data and financial data to talk to their leadership. So I'm not going to go more in depth in all of the goals of the clinic systems at this time, but if your clinic system has not yet gone through this process, please start to think about it. And also we want to have some opportunities for clinic systems to come together and discuss and brainstorm this year. So this is in our final year of funding for sustainability planning and CCSP. We're going to continue to provide support to all of you to implement your plans, whether you're starting at the beginning or you've really gone through a lot of your plan, seeing how we might need to adapt based on changes in the strengths and areas and improvement, what changes have happened due to COVID-19 or other changes in your organizations. So we are going to have each clinic system, if you haven't taken the PNSET, if you have already taken the PNSET, take it a second time to see what adjustments you might make, and continuing to work with all of our partners on what clinics are identifying, how as a colorectal cancer screening community, we can all come together, and all of those working on cancer screening and navigation to really support this work so that it can continue to live on even if CCSP does not continue to have the same grant funding, but what other opportunities are there out there to support this work? So that's really what I wanted to do at a high level for highlights on all of this. There'll be definitely opportunities to talk a little bit more about the current status.
Awesome. Also, thank you a million. And I just want to say a huge thank you because I know the data that we have comes from all of you inputting every month, weekly, as well as coming to the trainings, learning about that coding. I think like Lori Workman said, that many people come to the program not knowing a lot about colon screening, but with the movement through endoscopy, pathology reports, the coding, you learn a whole lot in this program. We couldn't have this data to report this sort of work without all of the great work from all of you. And a huge thank you to Elsa. I would have to say of all the young professionals I work with, Elsa probably learns the most quickly about a fantastic balanced approach to getting what you need, the relevant data information being efficient and not over or underworking things. So Elsa, thank you so much for all of your great work, and definitely a strong leader even at a young age. And we really appreciate all the great support that Elsa has provided as well. And a huge thank, because I know some of the reporting can be daunting for everyone. And our health department and team members need a lot of this to substantiate the work for CCPD. So huge thank you, Elsa, for all of your great work and leadership. Elsa, I think, are we ready to move to Christy, our Executive Director of our state coalition, to share some perspective?
Yes, and again, echoing what Andy said, I can't thank all of you enough for all of the time and hard work you dedicate to the program.
All right, Christy. So everybody, while Christy is getting prepared, we want to just also thank you again. Our Cancer Coalition has been a guiding force. Our colorectal task force has been a longstanding advisory committee and team member for CCSP. So under Christy's leadership, we've seen the coalition really prevail over the last couple of years, and now as its own standalone 501c3, we're really excited to have Christy Cahill, who is our Executive Director and Cancer Fearless Leader in Colorado, share some perspective. So Christy, are we ready to go?
Yep. Elsa, do the slides look okay?
Yes, I do.
Great. Thank you, Andy. As Andy said, I'm Christy Cahill. I'm the Executive Director of the Colorado Cancer Coalition. Thank you for having me here today. I'm just going to share briefly what the coalition's all about and ways that we support colorectal cancer screening in the state. So the coalition is the statewide network dedicated to eliminating the burden of cancer in Colorado. And how we do that is by engaging, facilitating, expanding, and strengthening partnerships across the state of everybody who's dedicated to improving the lives of Coloradans touched by cancer. So our membership is made up of people that work in clinics just like you, people that work in nonprofits, oncologists, radiologists, other specialty physicians, people in public health, and researchers and academia. So we really, anybody that touches cancer anywhere in their work is a member. We also have survivors and caregivers. So everybody has something unique to bring to the table. Our other ways we do our work is with our task forces. So each task force has 2 leads who help run the task force. We've got the colorectal cancer task force, HPV vaccination, lung cancer, skin cancer, and survivorship and palliative care. We also have a few working groups community outreach, provider education, and policy. And so now I'm going to dive a little bit into the colorectal cancer task force. So these are their newest priorities that they've just set this year. So they're going to focus on providing education to employees, to educate them on the colorectal cancer screening guidelines, hopefully have them advocate at their own place of employment for colorectal cancer screening policy and time off to go get cancer screenings, and ultimately to improve cancer screening rates. They also have had a really strong presence every year during March, which is Colorectal Cancer Awareness Month, as I'm sure most of you know. And they want to continue having a strong presence then by hosting some educational webinars and presentations, doing a few targeted media releases, and partnering with 2 organizations, making 2 intentional partnerships to help and sustain that the whole year through. The last piece is they want to improve provider knowledge around colorectal cancer screening guidelines and shared decision making. So they've presented before at the Colorado Business Group on Health conference. So looking for opportunities like that, where they can hit a lot of people with the messaging and try to get the word out there about the importance of colorectal cancer screening. And I think, right now they're definitely focusing on what are those virtual opportunities they can do in this current COVID-19 crazy time. So some other things they have done, like explored the links of care to, figure out, we'll get an email of so-and-so has this issue, they can't get in. So they'll work with Andy, they'll work with others to try to get patients to where they can go in and get a colonoscopy. They're just it's a great place to network, learn from other people who are working in colorectal cancer. We really focus on providing that educational opportunities and networking opportunities. So they meet monthly in the morning to try to get it in before the workday starts. So I don't have their meeting time on here, but I can make sure that Elsa sends around their meeting times in the minutes. Some other things the coalition does are quarterly meetings. Our last one just focused on implicit bias, and everybody took an implicit bias test on race, and we had a discussion around it, and it was just a great enlightening conversation. We have started hosting some peer-to-peer sharing meetings, so hopefully you'll hear some more about that soon. We work with a few partners across the state, including CCSP, to host those. So you should be hearing more about that soon. We've had Navigator Night Outs in the past, and we hope to eventually bring those back. And so right now we're just sharing items from the Patient Navigation Training Center. I know they've got their Tai Chi and other things, so we help promote those to make sure people can access those. At each of our task force meetings, we encourage them to have guest speakers. So the Colorectal Cancer Task Force is actually really good at bringing in a variety of speakers at each one of their task force meetings for that educational component. We are also doing an inaugural lung cancer symposium. It initially was going to be a full day meeting in person, and now it's going to be stretched out over like 1 hour over 7 or 8 weeks. So if that's something that interests you too, we'll make sure that gets sent out. And we host a symposium every year. This year again, it will be virtual. It's November 5th and 6th. So it'll be free to attend, so you can look at the agenda and see which sessions make the most sense for you. And then we also host ad hoc webinars as we hear of needs for members. So this year we've done a few on COVID-19 and how it's affecting cancer patients and how it's affecting clinics. And we've also done a few on financial toxicity, and those are linked on our website. So some other partners we work with and other things that we've helped produce. So the Colorado Cancer Coalition we're funded through a grant from the Colorado Department of Public Health and Environment as well. And part of that funding comes with helping to produce the cancer plan. So we help find volunteers to contribute to the cancer plan and really make sure it's a statewide cancer plan and gets voices from everyone across the state, and isn't just written in a silo. So right now we currently have the 2016 to 2020 plan, and the 2021 to 2025 plan is currently being rewritten as we speak. There is a committee soliciting feedback and putting that together. And it's a very open process. So if you've ever had a chance to look at the cancer plan and you've thought it's missing X, Y, and Z, there will be a public comment period where you can provide those comments and even engage more as a committee member in helping write it. So that's another way we partner with the state and other partners across the state. To talk a little bit about the policy side, RJ is going to go deeper into this, but the coalition has funding from Fight CRC. It's their Catalyst state-by-state advocacy program. And so last session, we tried to get a bill passed to reduce the screening age to 45 and to remove the patient cost sharing for follow-up colonoscopies after a positive non-invasive test. And it was moving along swimmingly until COVID-19 hit. And once the session paused, the bill, when it came back into session, the bill just couldn't get across the finish line. So we're already starting planning now to run that same bill again and try to get it across the finish line this year, as well as we're exploring some access to care issues and looking at possible ways that the coalition can help figure out, how to get those people that are having trouble finding colonoscopy care, like helping with that links of care and that access to care piece. And then the third piece we're working on is collecting more stories to help accomplish both of these goals, as well as more intentional partnerships in this realm to help get these across the finish line. So that's all I have. Andy, is there anything else that you wanted me to address that I didn't address in the slides?
No, I think, Christy, you did a bang-up job of being very comprehensive. What I would say is the colorectal task force is a strong part of the coalition, and that if you have an opportunity to attend to the meetings, drop into a meeting, even if it's sharing an idea or a need, even if you can't attend every or all the Thursday early morning sessions, it's a great opportunity to network, to share about resources or needs. So I just want to say thank you. As Christy noted, the coalition and CCSP have done a lot of good work together in terms of programming. The regional meetings and a few other pieces that we have for programming really actually were in dual opportunities. So a lot of great resources, the annual meeting coming, a lot of awesome opportunities. So thank you, Christy. Again, I think Christy is paid at halftime, but probably works 1.5 times. So yeah, she does a lot of commitment and energy, and without her, we wouldn't have such a strong coalition. So Christy, thank you for being a huge advocate of our program and our clinics and all the great work. So I'm going to go ahead and transfer to RJ Ours, who I know is joining us from our American Cancer Society Cancer Action Network. RJ, can you hear me?
Yes.
Okay, awesome. There you are. So I really love, I got to tell you something about COVID-19 and all this working at home. I really love to see people and what's going on in their offices. So I want to ask you, what is that? Is it, what is the little pendant in the back, the college?
That's my alma mater, the now gone College of Santa Fe in Santa Fe, New Mexico. It was a 4-year liberal arts college that the Christian Brothers ran for like 60 years. And like a lot of small colleges, it just didn't make the transition to the
big time.
21st century too well. So
yeah, well, but I really love that opportunity to drop in, and I apologize, my camera isn't working, everyone, but RJ, we're really delighted to have you. I think sharing some perspective as a longtime partner and advocate from CCSP, as well as just hearing about where ACS is going for colorectal cancer and cancer initiatives at large. Would love, I think, probably over the next 10 minutes to hear from you, RJ, about some perspective.
Sure. Thanks, Andy, and good afternoon, everybody. You know, Colorado has been fortunate over the last 12 or 13 years to really be at the forefront of opportunities with colorectal cancer screening and early detection. I was happy to help pass a bill in 2008 that required coverage of colorectal screenings by private health insurance and other insurance regulated by the state of Colorado. You know, in advance of the Affordable Care Act a couple of years later, which then required that nationally under our current system. So Colorado was a little ahead of the curve. We were fortunate, as Andy discussed a little earlier, to have benefited from Amendment 35 tobacco tax revenue beginning in about 2007 with the wonderful screening and treatment program that her predecessors with the program put together, Dr. Tim Byers and Holly Wolf, that screened and treated thousands of Colorado residents for colorectal cancer. And then unfortunately in 2013, that program went away as circumstances changed and priorities changed. But here we are back again with the new science on colorectal 45. Since it was announced in the summer of 2018 by ACS that colorectal screening should beginning at age 45, because it's been determined that more and more middle-aged or younger middle-aged, younger adults were getting diagnosed at earlier ages, at later stages of cancer. We still don't know exactly why that's happening, what factors are contributing to this colorectal cancer situation, but we went to work fairly fast as an organization to begin to recommend that states try and lower the age of screening coverage for colorectal screenings to 45. There were a handful of states in 2019 that either quickly adapted their existing statutes or proposed completely new amendments to statute to do that. And then we joined them in trying to do that this year. And we had a really strong coalition. We had great sponsors. The calendar, the COVID outbreak, and unfortunately a certain feeling against insurance mandates this year, this session, kind of worked against us. But be assured that ACS CAN and our partners plan to work very hard in the coming months to lay the groundwork for a return bill in January to get that introduced and work very hard in the next session to get not only the age lowered to 45 for coverage, but we also want to close that gap on follow-up screenings to non-invasive screenings, colonoscopies to be covered, any resulting lab work and so forth covered by health plans without out-of-pocket costs. So we believe that those things together will help lead to earlier detection, maybe even prevention of cancer, and certainly better outcomes for patients if they can get diagnosed early and effectively treated. We'll need everybody's help in doing that. Again, next session, some other things on the horizon that ACS CAN looks forward to working on as well are or include perhaps the reestablishment of a screening program for those that remain uninsured and don't have access readily available to colorectal screenings going ahead. I think that program from 2017 to 2013 was so successful And I would like to see that reestablished. So we'll begin looking at our opportunities and options to work toward that effort, and in other ways that we can help get that screening rate in Colorado to 80% and beyond for everyone over 45 years of age. I'm happy to take any questions or have some discussion.
Great, RJ, thank you so much. So I guess the one thing I would say is we're really excited to have ACS and the coalition being able to, I think, share perspective, provide opportunities to help advocate for the work. That's not something the university or CCSP is able to do directly, but we are really always available for sharing data about our program, our outcomes. And I just want to reiterate, I think RJ, as ACS and the coalition and others start to look at voices for these campaigns and talking about the value, there's always an opportunity, RJ, for people to have a voice in this if it's something that your employer or you're in a setting that allows. RJ, is there any specific way that people can get engaged as a civilian or in their work? What would you recommend based on your work with ACS and being that lobby part of our organization in Colorado?
Yeah, thanks, Andy. You know, I mean, certainly I understand that anybody that works for a public agency, a government agency at the county or state level or federal level for that matter, you know, you are precluded from doing direct lobbying, but I think we all have a voice on our own time, and you know, joining ACS can so that you get on board with our informational resources, our network, to be apprised of when you can take action as a private citizen through an email action alert to your legislators or others when there's pending action is a great way to get involved. You can go to fightcancer.org and look at how you can be involved as a member of CAN. If you work for an organization that isn't precluded from lobbying, certainly the more voices we can bring to bear with legislators, the better at the state level on this. Grass tops are a great option to have on your side. That is, you know, significant individuals, corporate heads, healthcare professionals that can lend their voice to this as well. You know, health systems and other entities that may be more of a private or non-public nature would be great to have on our side as well, to help us lobby, to help us with our grassroots engagement. Does that help, Andy?
Yeah, it does. And I think, you know, Christy had shared a little bit about some of the work that the coalition is doing. And I think even for the coalition and even sharing, you know, the voice of a navigator, or sharing perspective about what navigators do, patient stories. I think at times people are really sharing, RJ, for the advocacy and lobby side about understanding what the clinical setting and what the experience. We'll try to, you know, with our partners such as you all, provide information about these opportunities. Any of you are always welcome, of course, with the link Christy shared, where there's a lot of cross pollination between our efforts with ACS CAN, CCSP, under the auspices of the coalition. Great ways to get engaged. But I just want to say, I think we're at an interesting time that I think that you know, it's interesting that I think people are really paying attention to the pent-up demand and need for screening that impact the cancer mortality. And then RJ, to your point, also the many people who will be losing health insurance without access to treatment as well, which is something we were. So we're here, we're doing the good work. We have the navigation and support from the program statewide for at least another year, but it's a really critical time. So we thank RJ and Christy for joining us today. I know that we're at 5 minutes or so. The CCSP program is going to be continuing to have the one-on-one phone calls with all of you for startups. So I think we've already had calls with about 5 or 6 of you to hear your needs. I do think Christy's point And as RJ mentioned, that need for direct medical services and payment for colonoscopy copays in certain areas of treatment or even non-invasive testing is something we're hearing. We are going to be thinking about how do we take this movement further? How do we talk about other opportunities for screening? What are we using from this evidence from the program, as well as what we're hearing from the calls from all of you about making the case? But we thank RJ and Christy, and I believe Ali Vane and several other folks from our coalition and other program partners are around the table hearing right now. So we will continue to advocate for prevention and control within the medically underserved. So thank you a million for everyone who's been able to attend today. Thanks. If you have any additional questions, let us know. I'm going to go ahead and punt Elsa to the wrap up of today's call and the evaluation. And again, huge thanks to RJ and Christy for coming on with us today. So Elsa, can you close us out today?
Yes, thanks everyone for joining us today. I also just wanted to remind everyone of our other CCSP programming happening this week. On Thursday at 11 a.m. we have our CRC evaluation reporting training. So a full review of the evaluation reporting metrics and how to complete the report for CCSP. It's a great refresher, even if you did join us last year or if you're newer to the work. So I'll send out that link in the follow-up. We also I do want to remind everyone that there is a new Qualtrics reporting link for this current fiscal year. So starting with all patients that were navigated into colonoscopy in July. So I'll also send out that new link again. It was sent out last month. We won't be doing a direct evaluation of this meeting today, but we will continue to do a quarterly evaluation of our monthly calls. And so please join us the first Tuesday of September for our September monthly call. Thanks everyone, and have a great afternoon.
Thank you.